can see the screen. Nikki, can you at least see it? I want to just make sure you can see it since we're on record.
Yeah, I can see it.
Very good. If anyone has any problems, I'm still kind of a freshman on the Zoom, but if there's any issues, raise your hand or speak up. If you can't see anything or you want me to clarify anything at all, I'm happy to do that. So I want to give you an overview this morning of research design. It's not only an otolaryngologist intro to clinical research. I'm glad that we have audiologists on the line with us, but this was geared for and given to otolaryngology residents previously, not only here in Kentucky, but also I've given this lecture to our Kenyan residents that we collaborate with in Nairobi, Kenya. Our objectives this morning are to provide an overview of clinical research methods, to present common pitfalls in research design and implementation, and then discuss some practical methods in developing meaningful research endeavors. There are some of you, especially the senior residents and chief residents, who have been very aggressive and very active in your research productivity. And I think that's really now the culture here and not an exception or an anomaly. And I'm very grateful for the work that you put into research, because I think you put out some very meaningful research findings, and I think you're very thoughtful and diligent about that. Nevertheless, I think it's helpful to refresh ourselves about research design, research methodology, because we should, regardless of whether we play a major role, research has a major role in our career or not, we should be really engaging with the medical literature and reading our literature in audiology or otolaryngology and trying to digest that and understand what it means. Is it accurate? Not only finding the pitfalls, but finding the strengths that are in particular research studies and determining whether this is right to use to influence patient care or not. That's really important. Let me convey 3 different resources to you. These 3 books, I think, have been very helpful to me personally and professionally as I've been engaged in research. The Designing Clinical Research textbook shown there on the left. This book just gives an overview about clinical research methodology, and it's a paperback book. It's not very thick. It's probably something that would be valuable to read or to review during your research rotation. It may not be a textbook that you come back to often. Certainly be welcome to borrow a copy from me. But I would encourage you to consider this as you look at designing research, and you can think about some of the nuances and the challenges. This middle book is fantastic, and I think this actually should be on your library shelf. How to Read a Paper, the Basis of Evidence-Based Medicine. There's multiple editions. There's a PDF version of this that floats around. But this particular book is really, really helpful for really getting into the nitty-gritty. It's a very short paperback book that shows you, just the nuts and bolts of really getting at the heart of a study, the strengths and the weaknesses. And then lastly is this How to Write a Lot, listed at the top, or listed on the right here. This particular book is also helpful for those that are, really trying to write their research, trying to write up their results, and just really struggling with how to make the most of it. It also addresses a little bit how you would write towards research grant funding. And so I can't necessarily, and that may be a topic for a future lecture on how to write a research grant or write an NIH proposal. That may not apply to most of you. But I think writing academically does affect you. It affects how you communicate with your colleagues and how you're able to also integrate what you read about as well. But this particular book is a nice resource as well. So I'd encourage you to take a look at that one as well. Well, in research, it's all about asking the right questions. We're posed with so many different questions, clinical questions, and I think the clinic is one of the wonderful places and the best places to come up with research questions. It's not necessarily in your mentor's office or There's plenty of places for inspiration with scholarship, but when it comes to research, the clinic, the bedside, the operating room, these are all places where we are beginning to pose research questions. Why does a patient with a free flap have a failure of their flap? What are the factors that would influence this? What are the factors that would influence the failure of a cartilage tympanoplasty graft? All the things that we're engaging with as we're involved in our normal activities should be generating questions. I think these are things that are good to talk about while we're in the clinic and also in the operating room. But putting those questions, moving towards research projects is really what this is about. And it does start with asking the right questions. This is my youngest son, Lincoln, a few years ago. And so, I think one question might be, when you look at him, is like, why is he wearing a hamburger hat and an ice cream vest? My questions actually go much deeper, like what went wrong with this kid? I mean, he's a crazy kiddo. We love him. He's wild, but this is, there's so many research questions that are around my son, Lincoln, but it's asking the right ones. When we think about research questions, we're going to talk about that first. We need to think in terms of, reframing that question into what are we really trying to accomplish? If we're asking a question, what is the cure for cancer? That's a good question, but is this a question that we're going to really accomplish, which addresses the next aspect of a research question? Is this something that's feasible? Can we accomplish something that's feasible? Can we do this work with our time, with our resources at our institution? Also, the research question needs to be interesting. Does this matter to you? I realize that we're in a gray zone, especially with residency, that there are times that you say, this research could not be any more boring or dry or frustrating. I mean, this is just the nature of life, that things that overall are good and are valuable to us, that we lose some interest, it loses its luster, and we're not as excited as we once were. But I would encourage you that if you're going to engage in research, that it's something that matters to you, that it's something that, it raises some interest, and it raises a level of energy in your mind, so that you're contributing intellectual property as well as mental energy to try to find the answer to that and design the research project appropriately. Not only is interest important just to maintain your motivation throughout the course of study, but it helps you to complete the IRB and some of the more of the mundane work and the research project itself, as well as working through publication, which is another gauntlet itself to try to get research published. And it's a game. I mean, you can submit, this exact same, a paper to one journal that's rejected, turn around and submit the same day to another journal, and it may be accepted without revision. So there is certainly challenges in the peer review process. Research also needs to be novel. Has anyone else published on this? You might have the most interesting, most feasible research question, but if that's a research question that's already been answered by somebody else, and there's been, a number of studies and a meta-analysis, regarding this kind of question, then perhaps that's not the right one for you to focus your research project during residency or during training, or perhaps for your career. But can you advance on that? Can you move the field forward by perhaps taking what someone else has done or learning from other people and then go a step or two forward? Your research question also needs to be ethical, in that we need to ask ourselves, will my research endanger subjects? And it's obvious that we should avoid endangering subjects if at all possible, or at least minimizing the risk and also minimizing the waste. This is true also of animal research, that are we minimizing the resources? Are we, if we have to do work on mice, for example, are we showing through our statistical analysis that we're using the lowest feasible number of mice possible to try to address this research question? So ethics applies to bench work as well as the clinic work as well. your research question should be relevant as well. And this is sort of the rubber meeting the road. Will this research advance the science or the practice of medicine? And that's what's practical or pragmatic about it. That do we finding that our research is relevant to our field? So how do we get a research question? Well, I wish there was a research Willy Wonka that I could just go visit, a magical research factory, and be awed and amazed by the research that's just growing on trees. But research research inspiration comes from lots of different places. You need to master the literature. The more that you're reading the journals, the professional journals that are a part of our journal club, and reading even beyond your own little area of interest. I mean, I'm encouraged to read beyond just the otology sections of Laryngoscope or the White Journal, that get inspiration and learn from the methodology of researchers in a wide range of fields. So, and you also can look outside of otolaryngology, or out of audiology. You can look in a broad number of fields to be able to learn a little bit about what people are doing in research. I think it's helpful to keep your ears perked for interesting talks or presentations or posters, talking with researchers, communicating with me or with Dr. Gupta or Dr. Fritz, Dr. Keckner, Dr. Valentino, your faculty that are interested in research and have been involved in research. So talking with them, not necessarily to always, what project can I find so I can get this assignment done and I can move on with my residency and the rest of my life. But again, just to try to gain some inspiration, and that hopefully sparks that very necessary interest portion of your brain. Imagination as well, and this is certainly where Willy Wonka was a master of just dreaming and just contemplating and thinking about where research can go and what things would be interesting to you based on the things that you see, based on the challenges, the frustrations that you have when you're in the emergency room or when you're in the clinic or when you're in the operating room. Also just getting really good mentorship. I know I would never have moved forward in my research career and had the success that I've had if not for the mentorship. So that's a critical element of developing the right research questions and formulating the right research projects, is just having the right mentorship. And sometimes mentors say, you'll do what I like. You'll like what I'll tell you to like. And that sometimes happens in our career that we're doing research. That's sort of somebody else's idea, but is a stepping stone for our own career. Here's an example of kind of, as I began some of the research that I've been involved in with health disparities, how do I move forward with trying to figure out what's going on with delays and hearing loss? And, when I was a resident and then as a fellow, I was a fellow at Ohio State. So I was seeing patients from the Appalachian region of Southeastern Ohio, but also as a resident here, obviously Eastern Kentucky, a major portion of our patient population. I had so many questions in my mind of why are these children showing up in our office delayed in diagnosis? Why does it seem like nobody knows how to do a correct ABR, or why does it seem like every time a pediatrician looks in, a 3-month-old ear, they say, oh, I think there's fluid and they might need tubes. And it just seemed like there were so many barriers and so many challenges, but really no answers of why kids are delayed in diagnosis. I was assuming that that was the case, but I think I came to a realization when I became a faculty member here that, is there really a problem? I mean, do we know? I mean, I think there's a problem because I'm seeing these, 5-year-old kids that don't hear anything, that don't speak, they're nonverbal. So I would say that's a problem, but is that more of a problem in Eastern Kentucky? I mean, maybe that's true going on in Lexington or in Louisville as well. So that's really why I had to kind of back up and ask a little bit more fundamental question. Are rural children delayed in hearing loss diagnosis and treatment? And notice there's two parts to that diagnosis and treatment. Those are two different research topics and ultimately end up into 2 different research papers for me. But this is what I posed first. But then as I asked one question and began to communicate with other colleagues and I found mentors, then I realized there was just this whole cascade of questions that we began asking. Well, how common is hearing loss in rural areas? Maybe it's a whole lot more common, and maybe they're not more delayed. It's just that there's more kids that have hearing loss. What are the patterns of hearing loss? Is it mixed? Is it just sensory neural? Is it congenital? What are the mechanisms behind hearing loss? How does it affect their social function? So you can see all the factors there that I was thinking about, just trying to describe the hearing loss. And then, I was also wondering, kind of on the far right side of the screen, are there interventions? Are there things that we could do? I mean, as a surgeon, that's what my mind goes to immediately. Like, okay, what can we do to fix this? Let's stop talking about it. Let's stop describing it, and let's just get to work to fix it. But as a researcher, you've got to think, yes, like a surgeon, but you also have to think like a scientist as well. You need to think about really understanding the mechanisms and the challenges that go on with trying to diagnose, for example, kids with hearing loss, but then treat it too, and understand what the factors are behind that. So let me get back to another element that I think it's important once we have some questions, is just to understand a little bit about the nature of research, specifically translational research. Translational research is focused on basically the moving pathway of research, of innovations and discovery within the field of science and research. There's multiple levels of translational research. So everyone, Terminator is a ubiquitous, social reference because everyone has grown up with a Terminator movie at some point in time in their childhood or young adulthood. So this doesn't T1 and T2 doesn't refer to the original or the sequel of Terminator, but T1, it refers to basic science research. So it's not necessarily always just bench research that's involved in molecular microbiology work. It is also involving basic behavioral work of understanding the mechanisms and the theories and the frameworks of behavior. This usually is a lot of work done by PhDs, sometimes MDs, certainly run bench research labs, but in collaboration. I think the importance of translational research is just understanding the importance of teamwork, that you engage with people who have skill set and expertise that you perhaps don't have. I don't think anybody on this call or in this lecture would view themselves as an expert in T1 research, but certainly we can integrate T1 research into what we do, learn from it, and then use that to then translate to the next level. So T2 is about finding those the connections and the way to move the research findings from the bench into the clinic. And this might be the development of an intervention or a drug or something that's based on what we learned on the T1 level. And this T2 might involve a clinical trial, for example, maybe a pilot study or an efficacy study on a smaller scale. We often don't think about translation beyond this, but there is advancing of the research beyond the T2 level. T3 actually refers to studying evidence-based interventions on a broader scale, a broader platform, if you will, of looking at research on a diverse clinical scenarios. Is a particular intervention that prevents a certain complication, or a certain drug that prevents a complication, is that effective in all clinics, throughout the U.S. or throughout the Southeast, or in all, not only clinics, but also in the hospital setting, an acute situation or a chronic situation, applying that intervention to a broader sense and a broader arena is T3 translation. And then you can move from beyond that to actually population health, nationwide. If these large interventional studies or multinational study. And with that T4 research, that's also research that you're doing to try to influence policy. So you begin to also look at things like cost effectiveness. There's a whole field of research called dissemination implementation, is on the science of how you implement an evidence-based intervention, and then or how you disseminate that widely. The research that I'm currently engaged in is incorporates some of this higher level of translation of how do we implement a patient navigator program throughout the whole state of Kentucky and all the different offices for children with special health care needs. So I think it's just important to understand a little bit about that translation. Okay, now let's talk a little bit about design. So what methods do we use to answer our research question? That's really what design is all about. And there's not any one right design for any particular researcher. You know, you shouldn't be sort of like the clinical trial person. I only do clinical trials. I won't do any other kinds of studies. I mean, that's a little bit elitist. You need to think about, you know, asking the right kind of question and using the right kind of design to be able to get at truth, basically. Observational studies are basically asking yourself, do I take a passive role in the observing the events in the subjects? Whereas a clinical trial is asking a question, do I apply an intervention and then examine its effect on these events? Like I said, it's not, one's not better than the other, they're just different, all are useful. Even my own research career kind of followed this last point to this progression of beginning with a descriptive study. Did children in rural areas, are children in rural areas delayed in diagnosis for their hearing loss? That's a descriptive study. We describe if there is a problem or not. Okay, a second question or second research project might be, which is something that I've done as well, but what are the factors behind the delayed diagnosis in rural children? So that's an analytical study. And then, you know, I work to develop an intervention or adapt an intervention for infant hearing loss. Does patient navigation or use of a patient navigator expedite the timing of hearing loss diagnosis in children? So I think it would have been foolhardy and a little hasty to just start with a clinical trial, because I wouldn't have learned, you know, much about, first of all, was there a problem and where might the problems and the barriers lie before I design the intervention. So I would encourage you, don't just think about only clinical trials and only getting to fixing the problem. There's a whole lot of information, things that you could learn about describing the problem and analyzing the factors that influence that particular problem. And you'll see when I look at then the overview of all these questions that were flooding my brain, I began to realize that, okay, I've got that main descriptive question, you know, are children with in rural areas delayed in hearing loss diagnosis or treatment? That was a descriptive study. And then I move more towards the analytical studies, such as, you know, do these factors affect children in other areas, or what factors are behind the delay? Those are analytical studies. And then we move on into the clinical trials. Sometimes other researchers or the whole field has described the problem, they've really analyzed all the factors, and we do need to jump into clinical trials. But perhaps if there's interventions that just aren't working or just aren't addressing the problem correctly, we may need to start back at the beginning with more descriptive and then analytical work. So let's talk about observational studies. We've got a few options here. Cohort study is an optional study where observations are made in a group of subjects and that's then followed over time. This can be prospective or retrospective in nature. A case control is where there's a sample with the disease and a sample without the disease, and then you measure predictor variables. The third type of observational study is a cross-sectional study where observations are made on a single occasion. Cohort studies basically come from essentially a Roman soldier terminology. A group of Roman soldiers were referred to as a cohort, and sort of thinking about just a mental picture of a group of soldiers that are all tightly packed and tightly knit together, and then they're marching together as one collective group. That's a way to think about, following this group of patients. That you don't want to lose this group, but you want to follow them over a course of time. It could be prospective in nature. This is where you would define the sample or the participants that are involved. You would measure predictor variables and possible confounding factors, and then you would observe then their outcomes over time. The advantage of this is that this is a kind of study that's useful for determining the incidence of disease. If you see a group of patients at a certain age that are that you're recruiting, and then you see who develops the disease and who does not, you can then assess the variables or the factors that may have influenced one group getting the disease versus another group not having the disease. The challenges with a prospective cohort study is it's expensive. It's not good for rare diseases or uncommon diseases, and it just takes time to follow these patients. Much more commonly performed are retrospective cohort studies, and this is basically all this data on this cohort's already been recorded. It's faster and it's cheaper, but the problem, it makes you a slave to the medical record. That, if you say, all right, I'm going to look for the incidence of, a certain condition within all the patients that we're seeing in the head and neck clinic, for example. And if you're following this cohort, you may be able to capture that group and know who it is, but the problem is you might not have all the information you need. You may not have accurate recording of important predicting variables or confounding factors. And so the retrospective cohort study is done a lot, but it's always something that we should incorporate into when we write up our results. We make the disclaimer that, listen, this is one of the weaknesses of the lack of consistency of the medical record to record all the details. A case control study is a little bit different. It compares two groups, one with the disease, one without the disease. So we start already with the two groups that we've got the known condition. Basically, what we're doing is we're calculating the odds ratio of a certain condition. So the advantages of this particular study is that it's useful for rare outcomes. There's a short duration with a small sample size, and it's typically inexpensive. The disadvantages are that there's bias and confounding bias and factors from sampling two populations. So maybe your sampling is not done correctly or equitably, or maybe you're not being inclusive in the types of people that are within the groups, and so maybe there is some bias there. You're limited to only one outcome variable, and in the sequence of events with these patients, it can be a little bit unclear. So let's talk then about the cross-sectional study. This is where all the measurements for this particular group is made at the same time. It examines associations, not correlations. So we don't know all the factors that may have led to this disease or this condition or whatever outcome we're looking for. But it does measure prevalence of disease. Who has the disease at a specific point in time? So, case in point, looking for prevalence of coronavirus, that we're performing regular cross-sectional data collection on a daily basis. We're trying to determine at any given moment who has the disease at this point in time. But we're also wanting to know who has had the disease over this pandemic, the course of this pandemic. In this condition, or in this type of study, we're measuring relative prevalence, which is similar to relative risk. Who has the disease with or without a particular exposure? It's faster. This is not so expensive. It doesn't take as much resources to be able to conduct this work, but you just can't determine the causation of this particular disease. You can find associations, but not causation. A case series is a little bit similar to this in that this is a sample of patients with the disease, and you examine the characteristics or risk factors. Don't really have a control group or a comparator group here. So not the strongest research design, the case series, but cross-sectional study can be useful. Now let's move on to an RCT, or randomized controlled trial. So this is the main type of the gold standard for performing an intervention study, or you have a drug or have a surgical procedure or something that you want to expose patients to see if it changes their course or the development of a certain outcome. It applies an intervention. It observes this effect over time. And this can be involved, can help you determine causality. You have to account for confounding variables, and you can address the confounding variables by randomization. You know, all the different things that can bring in questions to your research findings. For example, like, you know, maybe in one group that got a particular intervention for a head and neck cancer, maybe there was a whole lot less smokers, and you were looking at primarily smoking-related tumors. And the group that did not get the intervention, or maybe got the placebo or the standard of care, that there's more smokers in that group. And so that smoking is a confounding variable. These are things you have to address for. But if you randomize, theoretically, that should help with trying to prevent the influence of this confounding. But we also perform multivariate analysis on the backside, on the end, to deal with, you know, if we control for smoking alone and try to take that factor out, and those that basically smoked, those that didn't smoke, and compare those as respective groups, was there actually an effect of the intervention to influence the outcome? So this is important when we do an RCT, to make sure that we're looking for and trying to identify the right confounding variables. And we may not know what those are ahead of time, but hopefully our original descriptive or analytical studies influence what we measure. We also want to blind during the RCT. This is eliminating the possibility that observed effect of the intervention is due to differential use of other treatments. The disadvantages of an RCT is that it's expensive. I mean, I have conducted randomized controlled trials. I'm in the midst of doing a large trial now that, I mean, it takes a lot of time, a lot of resources, a lot of people to do this kind of work. And so it is time consuming. It can only address a very narrow clinical question. And so if you really want to conduct the right RCT, you really got to be very specific. You know, does this, you know, new therapeutic cure cancer? Well, we can't cure all cancers with one therapeutic. You have to be very, very specific about the type of cancer, the stage of the cancer. I mean, there's a lot of, you got to be very, very specific about it. And we also realize that the intervention that we develop could cause patient harm. Maybe not directly. It's possible, certainly, that interventions are directly harm patients, such as a drug side effect or a surgical procedure. But it's also possible that the lack of getting the standard of care could be a form of harm as well. So take that into consideration. Let's talk about our study subjects. So when we talk about you know, who we might do research on, we think about populations. We can't likely do research that's feasible, at least with our resources, on the entire population. We can't do research on everyone in the United States, for example. We say, well, okay, maybe we can't go and do research in Arizona, but you know what? We could recruit lots and lots of patients from Kentucky. You know, so maybe Kentuckians are an accessible population, but are you really going to do research on every patient in the state of Kentucky? Probably not. You need to choose a sample. So use this terminology well. So I think this is important when we're describing research. Don't talk about, you know, two different populations when you really mean to say two different samples, a control group and then an intervention group. So use this right kind of terminology to think about this, that a sample is this smaller, chosen group of individuals, maybe because of accessibility or the ability to recruit them. But smaller samples do limit your generalizability. So if we only study patients that come through our head and neck clinic, we can't necessarily generalize all of our findings to all head and neck cancer patients in the United States or throughout the world. So perhaps there's a lot of differences in mechanisms and presentation, other, environmental factors that can influence outcomes or what have you. So bias is a big problem with study subjects. So, clinical versus the community, who are the kinds of patients that come to our center versus who shows up in the community, what types of thyroid operations are done at UK versus what kind of thyroid operations are done in the community by the community ENT doctors. Also, what kind of perforations are we managing? My practice is made up of patients that have had multiple surgeries before or been draining for 30 years, whereas maybe some of those that present in the community have smaller perforations or maybe have never had a surgery before. And so that could influence outcomes by just the different populations that are in different locations. And so we choose our sample. We may not be able to change that, but we have to describe our sample well. The inclusion criteria is important to define this ahead of time and to articulate this in your research. Who they are demographic-wise, what's their disease or what's their clinical characteristics, where are they located geographically, and then just other temporal characteristics about them. It's also important to have appropriate exclusion criteria. Those patients that are highly likely to be lost to follow-up may need to be excluded because you don't want to lose that data and have wasted those resources on those patients those participants that you really weren't going to feasibly get them through the study anyways. If you really can't get any data from those participants, then you need to be able. And this is not just picking and choosing. We determine the exclusion criteria a priori, but it's something to really think about. I don't think we always do that, and sometimes this is why we get frustrated. Like, I can't get anybody to stay in the study, or I can't recruit anybody in the study, and maybe because of our criteria that we're using. We may also want to exclude those patients that are going to have a high risk or high likelihood of an adverse event, just for the sake of, ethics and safety for patients. Let's talk a little bit about variables. So variables relate to the validity of a study. Depends on how well the variables designed for the study represent the phenomenon of interest. So you have to choose the right kind of measurement for your outcomes. There's different kinds of variables. We've got categorical variables, nomial variables such as gender, male, female, blood type, different measurements, measure counts or proportions. We also have ordinal categories such as tumor staging. We also might have means, be able to measure medians as well. And there's also then continuous variables such as weight, for example. And in that situation, you want to measure means and standard deviations. So there's choosing the right outcome variable is really important in how you design your study. And maybe you take a patient that, if you care most about, flat failure, then maybe it's a dichotomous, categorical variable, yes or no, the flat failed. But maybe what you're really, more concerned about is not flat failure, but maybe the timing of a failure. So maybe you're looking at time and more of a continuous variable, or there's just so many different ways that you can try to address the same issue. Maybe you have a research related to flat failure, but how you measure and record your outcome is really, really important. It also will affect how you analyze the data after the study is completed. Precision is a degree to which a finding is reproducible. And the more precise a measurement, the greater the statistical power is at a given sample size. And there's three things that affect the precision. There's observer variability. That's choice of words in an interview or the skill in using that particular instrument to measure that. There's also instrument variability, environmental factors such as temperature, different reagents. If you're using a flat monitor, does that instrument alone have natural variability? You know, is the monitor going bananas when the flap actually looks fine? There's also subject variability, intrinsic variations and rhythms that go on in the biological system that you're studying. There's a huge amount of variability that certainly occur in patients, especially after a surgical procedure. Precision is a function of random error, and that relates to chance variability. So we enhance our precision, the precision of our research. We want our research to be very precise, our measurement to be very precise. We can enhance this by standardizing how we measure. You know, we do it the same way every time with the same person, same time of day. So just having a protocol for how we measure it. And that all patients, in this research study, we measured all patients at 24 hours after surgery. Well, we don't want to take that measurement at 36 hours or 12 hours. We said in our protocol, we want to do it at 24, you've got to do it at 24 hours. So that will enhance your precision in trying to reduce this chance variability. Also training and certifying the observers, making sure that people that are maybe taking measurements or involved in collecting data are actually doing it the same way using standard techniques. Also refining the instruments so that we get better, more accurate or more precise tools, such as perhaps a digital thermometer versus mercury. Repetition is also important. The key of reducing random error and improving precision. So repeated measures over, maybe a short period of time, or perhaps even it's different research staff involved in taking the same measurement, just to ensure that this was correct. This wasn't some variability that was built in. That was precision we talked about. Now let's talk about accuracy. Accuracy is the degree to which results represent the true validity of the findings. And accuracy is a function of systematic error, and this relates to bias. So there can be observer bias, which is a distortion in the perception or reporting of a measurement, maybe rounding down the blood pressure. It also could involve instrument bias, which is perhaps faulty function of the machine. It's not calibrated correctly. If our audiograms were not calibrated correctly, then we couldn't trust the audiologic data that we're collecting on hearing function. We also can assess subject bias, the distortion caused by a subject's input. So this could happen if we were, conducting a questionnaire study on pain medication use. I just reviewed a study looking at pain medication use after ear surgery, and patients were given a questionnaire and they reported back on whether their pain was controlled well or how much pain medicine they took. There's all kinds of bias from the subject that could be engaged or be involved with that. So we have to be aware of that with questionnaire studies, certainly. How do we improve our accuracy? So we could standardize our measurement methods. We can train and certify our observers. Again, similar to the precision, we can refine or automate the instrument or the data collection, making unobtrusive measurements that the subject perhaps is unaware or is not, consciously contributing to the data collection. Certainly not to be secretive or to be, nefarious about how we're doing research, but that's one possibility, to unobtrusively collect measurements. We certainly can do that with our flat monitors that Dr. Keckner's brought into our institution. The patients aren't necessarily aware if the monitor might be changing, but you can collect data on your phones, for example. Also, one of the important things, like repetition, was really helpful to improve our precision. Blinding is actually really, really important to help our accuracy. So it helps to eliminate some of this differential bias and improve our overall accuracy. So blinding our researchers, which is the intervention drug, which is the placebo. We don't have different emotions or different ways that we are presenting the research, or only giving that, intervention drug to the ones that think will have better outcomes or do well, and those that have the placebo have the worst conditions. I mean, we don't want to influence the results. So blinding the researcher, blinding the participant to the intervention is helpful to improve that accuracy. Let's talk a little bit about statistical issues in our last few minutes. So, you can make your data say anything you want it to say. So lying is so easy. And this is an important issue that, do not, I mean, there's reports and there's, cases every single month that the NIH, submits and puts out there widely of cases of fabricating data, basically plagiarism or some type of other dishonesty, unethical use of federal funds in NIH conducted research. And it's a shameful thing. And what you should think about is that, don't lie. Don't use your data to tell things that aren't true, and don't fudge, don't, round up, don't change the data so that you can get something published. This is tempting. There have been people that have fallen to this temptation over time, but be truthful about what you say, and try to, bring in statisticians and bring in levels of accountability to make sure that you're being ethical with the data. Ultimately, you would have wasted the time, and you're doing a disservice to those that participate, allow you to use their body to conduct research. And you're also, if someone else reads that research that you have falsely fabricated that data, and they try to treat patients, and those patients have adverse outcomes because of that research, you are involved in that, and you are a part of that negative outcome. So this is a weighty thing. If you don't have the right numbers, you won't be able to answer your question appropriately. So we really want to be able to conduct sample size calculations to give the impression of statistical objectivity. Sample sizes are ballpark guesses, but it's not just throwing darts. It's not just picking a number out of a hat. It's a meaningful way and a somewhat of a objective way to come up with a number that we think we need to conduct the research. And that will all start with a hypothesis. We've talked about all this process here of asking research questions, generating hypotheses, collecting data, describing data, and then evaluating the strength of the evidence of hypothesis. The statistical work doesn't just begin down here at the bottom. That we need to use the statistical consultation and communication with a biostatistician all along, even when we're beginning to ask our research question, to make sure that we're trying to determine the right kind of question that's answerable. The hypothesis comes from a good research question, and it's simple and specific. The null hypothesis states that there's no association between the predictor and the outcome variable. It's the formal basis for testing statistical significance. The one-sided hypothesis specifies that the direction of association between predictor and outcome variables, whereas a two-sided hypothesis states that there's no association, but does not specify a direction. So perhaps that particular outcome could be increased or could be decreased, so we don't necessarily know the direction of it. There's different tests based on a one-sided or two-sided test. Here's an example of a hypothesis development. Let's say we've got an example here from a research question. What's the effect of intratympanic dexamethasone on sudden sensorineural hearing loss in adults within a 3 weeks of onset of the symptom? So that's an example of a situation. Our hypothesis could be good or not so good. A not so good example would say that, well, use of intratympanic dexamethasone is associated with hearing loss symptoms. Okay, that's not very specific. We shouldn't have a hypothesis like that. A better example would say to come up with a very specific, clear hypothesis that says patients that receive 1 intratympanic injection of dexamethasone at this dose, 24 milligrams per ml, will have improved hearing thresholds as measured by the pure tone average than those that receive no treatment. This is being very, very specific about the patients that have substantial hearing loss that get 1 dose of this particular dosage of dexamethasone, and then this is how we're going to measure that outcome. So much better than just that vague dexamethasone is associated with hearing loss symptoms or associated with hearing loss improvement, for example. The more specific you are, the easier it is to develop your analytical plan. And so the dependent variable in that situation was hearing loss symptoms. That was a continuous variable that we measure maybe with a pure tone average. The independent variable is actually the treatment condition. That's whether you get intratympanic dexamethasone alone or no treatment at all in that particular example. Knowing which is dependent, which is independent variable is important. Here's another example, new drug for substantial hearing loss versus oral steroids in the standard treatment. A null hypothesis would say that there's no treatment difference. An alternate hypothesis would be new treatment will decrease the pure tone average over standard regimen. So in this particular type of hypothesis development and testing, we're either going to accept the null hypothesis that there is no treatment difference or reject the null hypothesis that there is no difference in the treatment. To determine whether to reject or accept the null hypothesis, we calculate that probability that the null hypothesis is true, and hopefully that probability is very small. Ideally, it's what we want, and that's 0.05, a 5% chance or less that probability whether the null hypothesis is true or not. So if that is a very, very small possibility, then we would reject the null hypothesis. Again, this is you've seen this before, I know, but just for a refresher, type 1 and type 2 error. So in a situation where the new drug is actually better than the standard regimen at decreasing the pure tone average, we would reject the null hypothesis that the new treatment is no different than the standard. That would be, in the correct situation. In the situation where the new drug is no different than the standard drug at decreasing the pure tone average, then the correct condition would be accepting the null hypothesis the new treatment is no different than standard. And so the type 1 errors occur when you're basically in this scenario here. And then the type 2 error occurs in this situation where it's actually better. So the type 1 error, by defining it, is concluding that there is a treatment effect when in truth there is not. In this case, we would conclude that the new drug is better at decreasing the pure tone average when it really isn't. It's a false positive. The type 2 error is concluding there is no treatment effect when there really is. In this case, we would conclude that the new drug is not better at decreasing the pure tone average when there really is. It's a false negative. Usually that's a type 2 error is an issue with the power problem in a research study. So the alpha is the probability of making a type 1 error. Beta is the probability of making a type 2 error. Again, this is often an issue. The beta is a problem with the power of the study. The number of participants that we have can cause us to have a type 2 error. A very small sample, for example, increases the chances of that type 2 error. Okay, here's the final points here. So I would encourage you, read that, at least one of those 3 books that I showed there at the beginning. If you're going to choose one of them, choose that middle one, How to Read a Paper. It's a very good one. It's a good one to have on your shelves. Also, I would recommend that you find a mentor. Get a mentor that you can communicate with. It's available, that you can work together to work through your research. Discuss research ideas with colleagues. Read. Just become a scholar. Become kind of like a Willy Wonka to take in new ideas and imagine and create things as it relates to research. Developing a close relationship with a statistician is very, very helpful, not just at the end of the study, but at the beginning. I know that's always a challenge trying to find them, but I think just communicating with me and communicating with other faculty about statistical issues is important. Use the resources that are around you. If you have ideas, jot them down. Write those questions that you're posed with in the clinic or in the operating room. Write them down. Those could turn into research projects. Maybe not for you, but maybe for someone else. And then apply for research grants. This helps you to actually conduct the work and forces you to put your thoughts actually on the word processor document and helps you articulate perhaps a better study. And as you learn from grants that aren't funded, you learn about maybe better ways to conduct your research. So this is a beautiful view of Mount Kenya. I wish I was there right now in the lovely town of Nanyuki, Kenya. This is Africa's second highest peak. Okay, everybody, do we have any questions at all? I know that was a huge run through and maybe way too much information for this early in the morning. But I'd welcome any questions that you might have. I don't see any chats. I don't see any raised hands. Anybody at all? We all good?
Thanks, Dr. Bush.